We talked about the male-female reproductive systems, and now we're talking about fetal development here. Those here, they have the placenta basically holding on to the little amniotic sac with our little tiny bean growing right there. I think my wife likes to update me with the size of the baby as it's developed. I think we got to some sort of small variant of an avocado, so progressing along quite nicely. Anywho, some things you can do. Sometimes you can actually do some testing of the baby when they're still in utero. So we have things like amniocentesis that we can do. This is obviously something you don't want to do too early. You want to make sure you have room to work with there, and so you can actually use ultrasound to make sure you're not going to be accidentally stabbing the baby in the head with a big needle. That is generally frowned upon, but that way you can at least go in and able to get some fluid there. It's good because you can actually do some genetic testing on that and make sure that all the chromosomes are in the right order and the right number. I remember seeing one time an argument on the internet where someone says, well, how many chromosomes do you have? It's like, I have more than you. I missed the point there. Right, but you can look for those sort of things. It's actually, we have other ways to do this nowadays. So like my wife, she was able to, and for the last baby and this one, we actually did a blood test where they actually took some of her blood. We're able to isolate out the fetal cells, and we're actually able to look to see, do they have any kind of chromosomal issues. You can even look to see what the gender of the baby is at that point, which is really nice. So even by like 11 or 12 weeks, we knew that it was going to be a female based on the presence or absence of the Y chromosome. So basically on the test results, you get something that says, hey, no Y chromosome detected. So there's still, still holding out a chance for a little bit that there's going to be a boy. Like, well, they didn't detect it. Doesn't mean it's not there. Y chromosome's kind of shrimpy anyway, but no, it was a girl. So it is what it is. Anyway, so it's important not to do this too early. It's usually 16 weeks or after is when amniocentesis can be done. So looking at kind of the molecular exchange across the placental barrier, so it's really important that the mother is providing enough oxygen and nutrients to the baby and still able to take away waste products. So you can kind of see the placenta here, how it develops. Notice here how the baby's going to have their umbilical arteries and veins. What do you kind of notice about the umbilical vein and arteries as far as what kind of blood they're transporting? Backwards to what we normally would see, right? Because here in us, our arteries carry oxygenated blood, right? And the veins are going to be carrying deoxygenated blood. In this case, remember, arteries are just things heading away from the heart. Veins are going to be things heading back to the heart. So in this case, if you look here very closely, it's the umbilical veins carrying oxygenated blood from the mother. It's been transferred to the fetus, and then the umbilical arteries are going to be containing deoxygenated blood, right? So it's heading away from the baby, heading over to the placenta, and you can see how it's going to be kind of forming in these little between these villi, where basically the mom's blood circulation is going to be coming in here. It's going to be providing a nice, easy way for exchange of molecules, including things like carbon dioxide from baby to mom, oxygen from mom to baby, and we can get rid of some of these other kind of waste products and things like that. And in some cases, you can see transfer of substances from mom to the baby. So what's one thing they always tell pregnant women not to do when they're pregnant? They should not drink, right? Because alcohol is very easily able to cross over through the placenta, and it can affect the fetus in several ways. What do you call it when you have a baby who's been exposed to alcohol? Yeah, that's pretty straightforward, right? Fetal alcohol syndrome. So it can cause very significant cognitive delays, and can cause some facial deformities and things like that. So we don't want that to happen, but basically you're going to see that there are some things that will allow for the baby to preferentially take up oxygen from the mom, even considering the fact that obviously this is not the same kind of partial pressure of oxygen the mom's getting from the atmosphere. We can still see that there's some things that allow for the baby to pick this up preferentially. And again, some things are going to be very easily able to cross over into the placenta. Other things might be either too large or say too hydrophilic, and they won't really be able to cross that well. So that's why whenever you're looking at, especially to bring it back to farm for a minute, whenever you're looking at drug references and you're looking at pregnancy and lactation, you guys ever heard of pregnancy categories? So there's pregnancy categories associated with all drugs. Essentially, it kind of tells you, there's A, B, C, D, and X. X, obviously, you might imagine is very good or very bad. X usually means there's no more baby, right? So X's are bad. A is usually pretty good, meaning it has no negative effects on the fetus. But you can see that we'll talk about it later, but a lot of drugs end up getting kind of lumped into this category of C, which basically means that we don't really have any information whether or not it's going to hurt the baby or not. And so in which cases, some of it can be dependent on like how easily can this cross over, and then once it does cross, does it have any negative effects on the fetus, right? So we'll learn more about pregnancy categories as we get into some of the farm stuff. We'll talk about it in we get to like female endocrine type stuff when we get to that in farm. Okay, so we'll see the molecules are able to diffuse across these tissues for exchange. So again, CO2 getting out from the baby into the mom and oxygen being able to cross over. What's interesting is the fact that in order for this exchange to occur, the fetus does not really contain a high level of actual hemoglobin. What they have is fetal hemoglobin, which is a little bit different variant in regards to the proteins that are involved there. The nice thing about that is that it's going to have a shift of the oxygen dissociation curve over to the left. And so what does that mean for the fetus? Yeah, so even at lower PO2 concentrations, because again, this blood is going from the lungs for the mom, eventually traveling down to the placenta. It's already lost some of that oxygen. So even though the PO2 is going to be lower, it's going to have a tighter affinity for that. So it can actually have the better ability for it to pick up oxygen from the mom, hold on to that, and then carry it back to the baby for delivery. Okay. Yes, ma'am. Well, it depends. So when you're looking at the tissues that it's delivering to, they'll have a lower PO2, which we said that will cause the curve to shift over to the right, which allows for dissociation, right? So as you get to either more acidic type of environment or the PO2 is going down, that allows for more of that to be offloaded into those tissues. So it all works out essentially. Even though it's binding tighter, when it gets down to lower tissue oxygenation levels, it can offload that. And then also when you think about the CO2 levels in the tissue, it's generating more CO2, which also puts it in a state where it's shifting that curve to the right and getting it to offload. Yep. So clinically, we see that even though it's fetal hemoglobin, it binds a little bit tighter. That's really only relevant for it to pick it up from the mom. It's still able to drop it off of the tissues just fine. Yep. And so I'm not going to talk about specifically about too much about fetal circulation, but obviously they're going to have very large differences in how they're going to be perfusing their organs. I'm sure you guys will get that a little bit later on in one of your other courses, probably from Dr. Nicholson. But basically, circulation through the lungs, through the heart, all is very, very much different from what we have here. We're just really talking about how, I guess, from mom to the baby at this point. But again, things like alcohol can cross very, very easily. It's a very lipophilic molecule, and that can go and have very deleterious effects to the fetus. And of course, everyone, at least most moms I know, end up having some degree of mom guilt because usually they do not know you're pregnant immediately, and so you always worry about, oh man, I had that mojito when I was pregnant and did not know it, and then they're like, my baby's going to come out and their IQ is going to be negative and it's going to be bad. Usually, it's not going to be a problem, right? So even seeing some guidelines are saying you could have at least one drink a day. Not that I would actually recommend anyone do that, but there hasn't been shown to be huge amounts, usually with kind of more chronic, higher doses.
There's what about binge drinkers?
Mm-hmm.
If they binge drink
Mm-hmm.
still
Probably, there probably is going to be some sort of, what were you going to say?
I was just saying, I have a friend that didn't know she was pregnant for 5 months,
Mm-hmm.
which is crazy, but she was drinking the whole time. It was her first birthday, and the baby was fine, but I don't know.
Yeah, sometimes we don't know what the long-term effects. I mean, certainly if you're kind of chronically, and again, that first trimester there, that's where you're really worried most about the organogenesis. That's where most of the development of things like the neural tissue in the brain, all that's developing. So again, you're possibly having drinking during that most critical time frame, and so it's one of those things where it's like, well, the damage is kind of done. But it's usually those more chronic ones you end up seeing where they're drinking heavily throughout the entire pregnancy. You get that fetal alcohol syndrome. I mean, for your friend, there could have been something where maybe there's a behavioral issue that developed because of that. Maybe the kid has ADHD, or there's a lot of things we don't know, which is why it's very hard to do these type of studies. We can't take 50 moms and say, you're going to drink super heavy, so here's your shots, and then this 50 moms are going to say, you guys can't drink anything at all. Hard to do those studies, right? Not really super ethical. So some of those things we may not have that information until we've looked at these babies after they've grown and developed and looking back, retrospectively.
Isn't there whenever you're first pregnant though, is the most common time you don't really know in that first trimester, and then you find out once you this is period or whatever. Why wouldn't they just do a large study to see the effects? Because almost everyone probably has this without knowing.
Right, so there probably are some information out there, but again, the moms who are binge drinking during the beginning part, are they going to be likely to be ones that will volunteer for that sort of study, right? Or there are things like registries where you can actually sign people up, where you can look at this kind of information. So I've not read the literature to see specifically what they've looked at and what they haven't looked at. That might be a good thing to check out to see okay, well, have they looked at moms who claim to have binge drink, during this time frame? And then also there's so much variability in you know, what does one person consider binge drinking versus another? They would have to set up that definition. And then, like, what's your recall? Like, I don't remember what I drank 3 months ago. Like, you know, I have no idea. So, you know, what kind of recall do they have, and how much can you actually establish that dose versus what the baby was exposed to? So there's probably a lot of variables there. We may not have ever the absolute final answer, but it's an interesting question though, for sure. So maybe check out the research and report back maybe. Okay. So looking at maternal changes, so basically you can see weight gain over, most of the weight gain actually ends up happening in the last 2 trimesters for the most part, but averages around 25 to 35 pounds. Is it always going to be this weight though? Some people will go much over this, some people will go a little bit less than this, but on average around 25 to 35 pounds. About 8 pounds of that is fetus. Like the idea of 8 pounds of fetus. Some fetuses are much larger than that. I can claim to have been an 11-pound baby when I was born. Yeah, and no C-section. So I thank my mom for going through that. This head did not always started out this big. No, I'm just kidding. So in addition to that, so around 8 pounds on average for the fetus. Obviously, if it's more premature, it'll be a little bit smaller. 4 pounds of amniotic fluid, a placenta, fetal membranes, and things like that. Around, you don't have to remember these exact numbers. I'm just kind of showing you kind of, you know, where this weight is actually coming from when the patient's pregnant. About 3 pounds increase in just the uterus. So again, you're getting a lot of hypertrophy of these tissues and whatnot. 2 pound increase in the breast tissue as that gets developed. 5 pounds from the extra fluid in the blood and the extracellular fluid. So again, they're taking in a lot of extra fluids. Also, you'll end up seeing them, what do pregnant women oftentimes crave as far as food goes? Oftentimes they want to get salt, right? So they get extra salt so they can get extra fluids, and they can hold on to that. So blood volume goes up because now they're having to divert some of that over to the growing fetus. And again, most of the growth in the fetus happens kind of in the second and third trimester. So that's where a lot of that ends up coming about. So it's really funny how some of these changes will occur, especially like with smell and different things like that. So like for instance, you know, some women will become very sensitive to certain smells, and it would just completely disgust them, right? So things they might have found, you know, enjoyable before. For instance, my wife, like I noticed before she was pregnant, she really loved sweets. So I would always like buy these little cookies from her. You know, it's public sugar cookies. These are like, you know, crack. So I would buy this for her. And like, where those things go, they're gone like the next day. And my wife's a very, very tiny lady, and so it'd just be like, I guess she ate them all. Okay, great. And then as soon as she was pregnant, I just noticed like, okay, well those cookies are sticking around forever now. Like, what the heck's going on here? She just didn't crave them anymore. Now all of a sudden, salty foods. And now it's like, you know, potato chips and, you know, things like that they're craving because they need to get the extra blood volume, and that the salt kind of helps with that. So you only kind of notice these kind of subconscious changes that are happening there due to that pregnancy. It's kind of interesting to see that occurs there. So they're increasing their blood volume. They're also going to be increasing the amount of fat accumulation. So around the rest of that is going to be around 3 to 13 pounds or so. It's pretty variable depending on the woman, kind of what her diet's going to be and how much she'll actually gain during that time frame. Generally, the metabolism is going to be increased around 15% or so. So especially later on, especially if you're pregnant in the heat of summer in Florida, you get pretty hot, right? So you can see extra sweating, and they just kind of have this feeling of being uncomfortable and overheating. So that can be one thing you see there due to that increased metabolism. As far as nutrition goes, they're going to have increased iron requirements, right? Because they're having to produce a heck of a lot more blood than they had beforehand. They estimate roughly that between the baby and the mom, they need roughly between 900 and 1,000 milligrams extra iron to produce that new hemoglobin. Normally, you may only have like 100 milligrams of iron stored up in the body at any given time. So this is, again, why you may have, they continue taking prenatal vitamins throughout the pregnancy because, again, even though they're not prenatal anymore, they still have that iron in there that they need. And so they can incorporate that to make new hemoglobin for them. Vitamin D and calcium is very important. Obviously, we'll talk about vitamin D a little bit later. But again, because they're generating new bones and things like that, so that's useful. And the vitamin K as well. Does anyone know what we use the vitamin K for? So remember, it works in the liver to do what? Yeah, make clotting factor. So there's actually some cases where, you know, especially women who did not have good prenatal care, the babies were born, and so just the trauma of being born sometimes could cause intracranial hemorrhages due to that pressure and whatnot because they might have been deficient in vitamin K and not producing a clotting factor. So that's going to be one thing you can consider. So again, hopefully they're taking good multivitamins, having a decently balanced diet, and they should be getting most of these nutrients in kind of on their own. And so looking at blood flow, they typically see cardiac output is going to be increased by 30 to 40%. So it's pretty significant by about the 27th week of pregnancy. And then interestingly enough, it kind of, you see it kind of goes up steadily during the second trimester and then kind of starts to dip down towards the end. So right around the time you have, sorry, the blood volume is obviously going to go down once they actually have the baby born, but they see cardiac output actually go back down closer to the time of birth, and not really sure where the blood's going to, but that's one of the things they're kind of, still investigating. Anyway, they'll also have increased aldosterone secretion, which we know aldosterone is very important for helping to hold on to more fluid by working. Where does it work? In the kidneys. We're at in the kidneys. Yeah, the end of the like kind of that cortical collecting duct, right? So not necessarily like in the medullary collecting duct, but kind of the very end of the distal convoluted tube into that cortical collecting duct. Aldosterone is going to be primarily working to help to increase reabsorption of sodium.
So because aldosterone also causes the increased secretion of potassium or excretion, would that be why we need to do that?
Well, vitamin K versus potassium, two different things, right? Right, so vitamin K is a fat-soluble vitamin versus potassium is just K, right? That's just, yeah. So they may have some increased potassium excretion, right? But they would hopefully be getting that in the rest of their diet, right? Or you can supplement, give them a banana or something. That'd be fine. So increased aldosterone, increased fluid retention, and then typically have 1 to 2 extra liters of blood in the CV system at the time of birth. So again, one of the things you worry about, especially, and we'll talk about this more when we get to talking about female medicine, when we get to the pharmacology section on that, is that they can be in a hypercoagulable state. So not only do you have increased blood volume, but which can potentially, if they're not hydrated well, they can lead to kind of sludging of the blood, and they can end up being hypercoagulable. They can actually end up leading to potential clots that can form. That's one of the concerns we have for certain women who may be more at high risk is clot formation. So we can give them prophylaxis for that, try to usually with a heparin or a heparin-like drug. But again, increased blood volume, they're having to urinate all the time because of this extra volume as well. So that's, again, frequently having to go to the bathroom. Also, when you have 8 pounds of fetus kind of sitting there on the bladder, it also will stimulate urination as well, right? And then respiration, typically you're going to find oxygen consumption is going up, about 20% or so. So decent increase there. Increased minute ventilation, so it should be having either increased rate of breathing or the tidal volume should be going up to increase that minute ventilation. And they will also have kind of an increased sensitivity to CO2 that occurs, right? So they should be blowing off a little bit more of that CO2, and you'll find that the actual partial pressure for CO2 for a pregnant woman closer to term is going to be a few millimeters of mercury lower than you would see for a non-pregnant female, which is kind of interesting. And then also having the fetus having to press up against the diaphragm, especially as they get bigger, can make the work of breathing more difficult. So if you ever, my wife especially, when she's towards the end of pregnancy, she's just like, and it's just hard because she can't really exercise that diaphragm to pull it down as far because that baby's kind of blocking the way, right? Looking at labor, obviously this is going to be when we have babies ready to come out. We have these powerful contractions that need to expel the fetus out, and usually this is going to be in response to oxytocin. So towards the getting ready for birth, you'll see increased expression of oxytocin receptors that makes the uterus more kind of sensitive to this, and will allow for kind of this positive feedback loop to allow more oxytocin to be released due to those uterine contractions. Also, you may find that prostaglandins can help from the placenta as well. Those end up starting to be released and can help with things like cervical ripening and kind of getting everything ready for the birth canal to allow for expulsion there. And then again, usually you can actually find, what I thought was interesting is you have rising levels of this corticotropin releasing hormone actually from the placenta. So the mom is kind of releasing, or the placenta is releasing kind of like stress-based hormones that just kind of stimulate and kick off the whole labor process. Hopefully it comes out head first. Otherwise you have, what do you call it when the coming out booty first? Yeah, it's in a breech, baby. So it's no good. So anyway, so looking at the fetus and then looking at the mother, you can have the hypothalamus here releasing that CRH, that corticotropin releasing hormone. That will stimulate the anterior pituitary, as we know. And then both of these will actually go down and stimulate the adrenal gland, start releasing some of those things like cortisol and whatnot. And so that will have positive effects on initiating things like prostaglandin formation. It will end up leading to increase in the oxytocin receptors, and that becomes more sensitive to that, which causes the uterine contractions, which will again further release more oxytocin from mom. And then obviously oxytocin from the moms coming from that posterior pituitary. Very frequently we'll put women on continuous infusions of oxytocin as well to try to help speed things along if they're not going along at a pace we like. Okay, once a baby's born, everything's out and everything's good, we like to, we'll have lactation and hopefully be feeding the baby through that way. So again, the mammary gland structure will be certainly better developed as the pregnancy goes on, as we're getting more progesterone and estrogen being released from the placenta. You see the mammary glands get composed of these 15 to 20 lobules. They get separated by adipose tissue. So you can see these different lobules that are happening here. And basically you're going to find these glandular alveoli that end up secreting milk and lactation. So within the individual lobule, you'll find these different alveoli, not dissimilar to the alveoli in the lungs. And they're going to be filled up with milk here, and then they can be released out when they have the proper hormonal stimulation. And so this is a really important place where drugs can also end up getting trapped, because you'll see the pH differs here in the breast milk versus what the actual serum pH is. And so you can have drugs that will cross over into the milk here, and then it ends up getting trapped by the change in pH. So they end up having a more charged kind of state to it, and they can't really get back out. So sometimes drugs will actually be concentrated into the breast milk, and then you can have an increased exposure to the fetus. And again, they also tell you what should you not do if you're actually breastfeeding. What should you not consume? Still alcohol, right? Because again, alcohol is still lipophilic. It's still able to cross in over into these alveoli very easily, and they can get exposed to the fetus. Unless you really want to put them to sleep, and that's probably okay, right? Just kidding. Don't do that. All right. So again, the milk is going to flow from the lobules to the lactiferous duct, and then out through the nipple. So nursing maintains these high levels of prolactin, and so really this is the main place where this actually ends up getting secreted. Prolactin also has kind of a negative effect on ovulation, and so actually you have some women who are in a kind of a hypersecretory state of releasing too much hyperprolactinemia, and that can actually prevent them from ovulating and having a second kid potentially. And certain drugs can also increase prolactin levels, but basically, me coming back from that posterior pituitary, I'm sorry, this is still coming from the anterior pituitary, but you're going to have also this prolactin inhibiting hormone, which is normally kind of in a higher expressed state that will actually prevent prolactin activity. So prolactin is going to be one of the big things that helps to stimulate the actual production of milk. Right, so you can see it coming here through the pituitary, stimulate milk production, but that doesn't actually help to stimulate the milk release, right, that letdown of milk, and that's going to be more related to oxytocin. So again, that's going to help to stimulate the contraction of those lactiferous ducts and allow for milk to be ejected out for hopefully the baby that's kind of sitting there ready to go. And again, yes, ma'am.
How long does it take if the mother doesn't nurse for the milk to go away?
About a week is what I was reading. So again, you'll notice that a lot of women who are still breastfeeding, like if they stop, the breast can still get very swollen with milk because they're still producing that. So that prolactin they're producing it, they're just never getting that oxytocin signal to release it. And so once you end up having that occur, it'll cause a negative feedback that will end up shutting down the prolactin concentrations and will lead to kind of going back to normal breast tissue essentially. But certainly, you could have someone who, as long as they're still stimulating breast milk production, they could be breastfeeding for years potentially, right? So you have those wet nurses and things like that that are just like professional milk producers, right? So anywho, so looking at the actual production of estrogens, progestins, you'll notice that prolactin has kind of a negative effect on the progestin and estrogens. After the baby's born, you don't necessarily want to go straight back to ovulating necessarily, unless you're a glutton for punishment, trying to raise 2 infants. Again, there's probably going to be 18 months between my first and second kid, so apparently we were not that too scared of the first one. But essentially, you're going to notice that the levels will be low, which will prevent ovulation, and the prolactin levels will have kind of this pulsatile nature, which it gets pulsed every time the baby's feeding, essentially, or when they have that suckling stimulation. Obviously, you can artificially do that because a lot of working mothers will still pump at work and things like that. Then that will still keep production going. It's not probably as strong of a signal as the baby actually doing it themselves, but is good enough to at least while they're at work they can still produce milk. Okay, so any questions on that stuff? Yeah, I'm not an expert on the woman, but I'm at least able to. Got 1 kid, so I think we did okay. Made it 1 year, didn't die off. I think we're doing okay. That's my barometer for success. Okay, we made it to the 1 year mark. Baby's still alive. Great. Next, we're going to talk about regulation of metabolism. We'll talk a little bit about nutrition and metabolism here. Okay, so classification of nutrition disease. This is going to get a little bit closer to pathophys, not too much specifically, but basically, when you're assessing a patient for their nutrition status, you're going to be looking for several things. So they can be in a deficiency state, right? So this could either be just in the amount of protein that they're actually ingesting, or it could be based on the actual lack of calories they're going to be having as well. They could also be lacking certain single nutrients. So they're missing certain vitamins or certain trace elements. Do you guys know what any trace elements are? Yeah, certain metals like zinc, we're talking about manganese, selenium. We'll talk about all those a little bit later. But yeah, so you can be deficient in certain nutrients, which can cause various disease states, as we'll see just a little bit later. You can have this starvation associated with malnutrition, this marasmus that occurs here. It can occur with kind of prolonged inadequate intake. It could be an issue with intake. It could also be an issue with absorption, or it could be an issue with the actual utilization of the nutrients you're actually taking in. Okay. So you can have this happen either someone who has anorexia nervosa, which what is that? just not eating, right, because they want to lose weight. Could happen with like major depression or certain malabsorption syndrome. So I see this a lot with kids who have cystic fibrosis. They have a really hard time with their exocrine glands being able to secrete anything because they have these really kind of thick, tenacious mucus secretions, and so the pancreas stops sending out things like lipase and protease and trypsin and amylase and all those things, and they have a really poor ability to absorb a lot of those nutrients, and so that's why we can supplement that and kind of help out with these disorders. But otherwise, if they didn't have that, they would have very severe malnutrition occur there. And on the flip side, overnutrition or hyperalimentation, just even from 2011 to 14, approximately 69% of the U.S. were overweight, and we'll talk about BMI in a second, how we calculate that. But BMI greater than 25 is considered overweight, and then about a third of them were going to be considered to be obese or having a BMI greater than 30. And so obviously this can lead to major problems. Probably most of the problems you'll be treating for most of your patients relate back to some degree of overweightness. So again, cardiovascular disease, hypertension, type 2 diabetes, stroke, all these kind of come back to usually a weight issue, right? And so probably most of the time what you're going to tell patients, so like, man, I want to take care of my hypertension, I want to take care of my diabetes, I want to take care of all these things. What drugs can I give? And you say, well, you should lose some weight. And patients might not always want to do that, right? Because that's hard work. So you can also have a lot of nutritional issues based on inflammation as well. So again, once you kind of identify the patient's at risk for having, say, malnutrition of some degree, you look to see what kind of inflammation status they have. If they don't really have inflammation, you can look to see that usually it's an issue of starvation related to malnutrition. So things like they're kind of chronically starving themselves, they have some sort of intolerance to certain foods, and they're causing, say, a lot of vomiting. That can be an issue, especially in kids. Some of it could be socioeconomic, so if you don't have access to food because of no money, that could be one thing. Behavioral issues, environmental, so all of that can be leading to these kind of starvation-related malnutrition. The patient's otherwise healthy, it's just they can't get access to the food they need, or they're choosing not to access it. On the flip side of that, you can see where inflammation and chronic disease can also affect our nutrition status pretty significantly. So to say mild to moderate inflammation, just having kind of chronic disease states, especially things like if you have organ failure or pancreatic cancer, all these things can lead to malnutrition. And then some of these kind of marked inflammation cases, think about major infections, think about sepsis patients, they have surgery, burns, all of that can also lead to major nutrition issues if you're not kind of proactively kind of addressing that, making sure they're getting enough protein, enough calories, enough all these other elements we're going to talk about in more detail. So how do we assess their nutrition status? They're going to be looking for certain risk factors. So you can look to see, like, okay, do they have any macro or micronutrient deficiencies? And do you guys know the difference between a macro and a micronutrient? What's a macronutrient? Carbohydrate, proteins, fats, right? So proteins, carbohydrates, and fats. Those are going to be your main things. This is the main source where we're getting our calories from, as we'll see. And then all the micronutrients are going to be everything else, essentially. So electrolytes, you're looking at trace elements, you're looking at vitamins. Those are all going to be considered to be your micronutrients. You're kind of assessing them to say, okay, well, are they having any issues, any obvious deficiencies with one of these? Also assessing if they're obese or not. We'll talk about some anthropometric measurements we can do there. And so you can assess them as well for looking for things like, do they have impaired nutrient absorption, right? So CF patients were a good example, or if they have, we have one patient I saw who basically, as a very small child, they'd accidentally ingested drain cleaner. Drain cleaner is a very strong base, and ended up kind of basically wiping out almost all their GI tract. So they ended up having to be on chronic IV nutrition, that total parenteral nutrition, because of that. They just had no functioning GI tract left, right? So you look at some of their risk for these related complications of not having any of these particular deficiencies, and then at some point you're going to estimate what their actual nutrition needs are. So we'll go over some of those calculations, how we can figure out what we should be getting to our patients. And then you'll kind of establish your baselines, what are your goals for the patient, and then that way you can kind of look over time, because again, you can't fix a lot of things nutrition-wise very quickly. It takes time for them to kind of get incorporated and fix these problems, over, say, weeks to months instead of something you can fix like immediately. Okay, so we mentioned nutrition intake and dietary habits. Do they have any history like anorexia? Could be related to they have unusual or absent taste. So, for instance, if you have very significant issues with taste or smell, like you may not be able to tolerate a lot of types of foods, which could lead to anorexia. Look at their dietary intake. Are they a vegan? Are they missing out on certain critical parts of the nutrition because they're trying to follow a specific diet? Certain religious restrictions may incorporate this. Usually, there are ways to kind of supplement the things you're missing out on based on the diet, but not everyone may know all of that information and may be missing out on certain critical things. Looking at specialized diets, are they on an enteral nutrition, meaning going through the mouth or through like a G tube or something? Are they on parenteral nutrition? So you have some chronic patients who are going to be on this almost lifelong. And then look at what type of supplemental, the vitamins, minerals, herbal intake, whatever they might be having that is trying to supplement in addition to what you're going to be trying to do for them as well. And then finally, food allergies, intolerances can be a big one. So for instance, you can tell me that avocados have all the healthy fats in the world you want, but guess what? I throw up for like 2 days straight if I have anything with avocado in it. No good. It's very sad. Guacamole tastes very good. I like sushi a lot. Cannot have it, right? So look for those kind of intolerances that may preclude people from getting specific types of foods. So you need to really kind of custom tailor it to whatever the patient is going to be best for them, essentially. And the nice thing, you're mostly, especially if you're like in the hospital setting, like you're going to have nutritionists going to help out with a lot of this stuff, and they can kind of be assessing this along with you to make sure your patients are getting everything they need. Okay, so looking at some of the underlying pathology of some of these nutritional effects. So if you have chronic infections or kind of chronic inflammation, these patients can be in this kind of hypermetabolic type state, which can lead to, even though they may seem like they're getting enough nutrients and enough calories, they could be kind of burning through these in an increased rate, which could lead to, which is why you need to kind of assess these things and make sure you're kind of upping their intake appropriately. But certain endocrine disorders can affect this. Certainly, we'll talk about like the thyroid gland, right? So if you don't have enough thyroid activity, what does that kind of do to your total metabolism? It decreases this. You may have cases where you have weight gain occurring because they're overeating based on their metabolic need versus they're hyperthyroid. They may be in a very hypermetabolic state, in which case they may be losing weight because they're not upping their intake of food in order to keep up with that. It could be the conditions like that, and certainly digestive or absorptive issues if they have chronic diarrhea, especially with a lot of patients who have like ulcerative colitis or Crohn's disease, which are major inflammatory conditions of the bowel. They can have very poor absorption of food. They have very severe diarrhea. They can have malnutrition occur from that as well. Okay. And so also looking at some of these end organ effects, so looking for weight change. Weight change is going to be one of the biggest things you're going to look over time. It looks to see what their fluid status is like, make sure they're actually gaining weight appropriately. Do this a lot for kids as well, as we'll see. Look for skin and hair changes. Typically, skin and hair. Why do you think those are sensitive to nutritional changes? Yeah, there's a huge cell turnover, right? So those are rapidly dividing cells, so you can see changes pretty quickly there. So the hair might get more brittle, it might get depigmented. You see the skin is going to look drier or more cracked, and things like that. You can all kind of assess for these things. And then looking for GI symptoms, and you can also look for things like exercise intolerance. Is the patient not able to get around like they used to, or are they, some other kind of objective markers saying like, hey, I used to be able to climb up the stairs, no problem, and nowadays I get super winded whenever I do that. That could also be a sign of nutritional issues. Okay. Also consider what's your patient's surgery history. So more and more patients have undergone bariatric surgery, in which case, it could just be as simple, something as simple as like a lap band, which is just kind of a restrictive band placed around the stomach. Could be an issue like that, or they could have had total bypasses a certain part of the stomach into different areas of the gut. So you'll learn about the Roux-en-Y and all those kind of things like that. But that can have significant effect on digestion of food, just on the amount of food they can actually ingest in the first place, because they have so much smaller space for the food to go. So they can have big issues with that. I'll never forget when I was on rotations, there's one lady who she was a nurse. She was out for a while and came back, and she'd had a gastric bypass done. So essentially, it was bypassing portion of the stomach. I think they estimate like the size of her stomach at that point is like an egg, essentially, right? So not very big. We mentioned, usually the stomach kind of holds like 1.5 2 liters of food at a maximum. They're cutting out a significant portion of that. And so I saw her eating, and of course we're we're in Putnam County, so there's a lot of bad food there. And she was like, "Oh, I'm gonna get my gizzards." I'm like, gizzards? Isn't that what the chickens use to grind sand and stuff that they get from eating? Or like, that doesn't sound like it's going to be good for your GI tract. Sure enough, huge GI issues ended up coming about from that. She ended up having to go to the hospital and put on IV fluids because she was vomiting so significantly. So, these are things you have to consider when they've had kind of surgical changes to the gut. Certainly, they have portions of the bowel being removed. So if you had part of your small intestine removed, that can lead to big changes in the ability to absorb a lot of nutrients, right? As we've already kind of seen. Gastrectomies, all that can be making huge effects here. And so certainly some of the miscellaneous things, look for things like catabolic medications, right? So when you talk about things like glucocorticoids like prednisone or dexamethasone, those are going to be catabolic in nature, which we'll look at in a little bit later. Look at other medications. Are they dehydrated because they're on diuretics? Their genetic background, and then you can also look at things like alcohol and drug abuse. Okay, so yeah, they're losing lots of weight, great, but they're also on cocaine. That maybe that's not a good thing. You guys ever seen there's an SNL skit one time with Jim Carrey where he did this weight loss program, and essentially he was just on huge amounts of methamphetamine, and said he was the devil, and it was very, very funny. So I recommend you look that up. So anywho, so looking at physical exam findings, so some things you can look for that can be an assessment of nutritional status. Things like edema, so they're having kind of increased amount of edema, increased fluid collection that's occurring here. So like ascites. We talk about liver patients, how they can have ascites, just a lot of extra fluid in the gut. We'll talk about why that is in a little bit later. Look for dehydration. What are some signs of dehydration? Okay. Dry skin, decreased skin turgor, they would say. Lack of urination, that could be one. Think about dry mucous membranes, think about sunken eyes. If it's a small child, they can have a sunken fontanelle right on top of the head. So if you see kind of a sunken in little portion there, that could be indicative of a dehydration. So lots of things you can look for there. They're having muscle wasting or loss of subcutaneous fat. That could be indicative of some kind of nutritional issue. Fever, tachycardia, alopecia, or that kind of dry, brittle hair you can see with that. All those can be signs of nutritional issues. Looking at the skin and mucous membranes, if you're seeing kind of thin, shiny, dry, or scaly skin, like those could all be signs of some kind of nutritional issue. You'll find with a lot of these like trace elements, if you're kind of chronically deficient in them, you can see lots of skin changes occur from this. Decubitus ulcers, so these kind of pressure ulcers that develop over time can be there. You'll find a lot of trace elements as well work with wound healing, and so we're missing a lot out on things like zinc that can lead to impaired wound healing. So these ulcers that can develop there. See areas of ecchymosis, stomatitis, stomatitis being those kind of sores in the mouth that can develop there. All can be issues here. And then look at the musculoskeletal system. They have a short stature. Kids who are chronically malnourished may not be able to grow to their full height potential. They can have bone pain associated with this. Muscle mass ends up being less than what you would expect based on their habitus or their exercise level. One of the big things I see issues with, especially with inner city kids, what potential metal could they be exposed to? A dangerous metal. Lead, yeah, so lead can be a big one, right? So we worry about lead, especially kids who are inner city and they may not have good access to things like vitamin D and calcium. Well, lead looks a lot like calcium to the body, and so these kids would end up preferentially uptaking lead into their bones, and you can see that on x-ray actually. So if you ever look up lead lines on bones, you can actually see the lines where they've actually been exposed to that, because the lead is more radio opaque than the actual bones are. So it's kind of interesting thing you can see there. So, continuing on with our physical exam findings, certainly we have some neurologic issues that will develop from certain nutritional deficiencies. We have ataxia. What's ataxia? Can't walk right. You're just kind of stumbling around a little bit. I'm sure you've seen some of your friends do that from time to time. Seizures could occur from this, paralysis, encephalopathy. All kinds of things can develop from this. Hepatic changes as well, so certainly if you are having hepatic damage being done here leading to nutritional issues, you can have jaundice, hepatomegaly can develop from this. This is certainly not an all-inclusive list, just trying to get your minds kind of starting to think about some things that may be indicative of, hey, maybe they don't have this issue that I'm thinking about, maybe it all goes back to nutrition, right? So a lot of times that may not be an assessment that you guys will make unless you start to kind of think about it. So also looking for things about assessments of inflammation, right? So we can find certain laboratory assessments. We can look for things like changes in albumin, transferrin, or prealbumin. We're going to talk about these as visceral proteins. We'll talk about more of those in a few minutes. You see certain lab values that are increased in response to inflammation. So we have one called C-reactive protein, which is something we'll look at when patients are suspected of having like sepsis. We'll kind of see what type of inflammation is developing there. Glucose is another big one, right? Because when you're in a high stress state, high inflammation, you're releasing a lot of glucocorticoids in some cases, which can lead to increased glucose, as we'll see in just a little bit later in this section. Increased amount of neutrophils. So these are all kind of things you can see on laboratory values. Again, clinical findings, certainly fever, hypothermia on the flip side of that, and infection, looking for things like, either in the urinary tract or looking for the lungs, all kinds of different things here. And then certainly some of these acute and chronic disease states can cause chronic inflammatory issues. Think about things like cancer, celiac disease, cystic fibrosis is a big one that we deal with. You can even see for some of these kids with such chronic inflammation in the lungs, you can end up seeing fibrosis that can occur over time, kind of scar tissue forming, which can impair oxygenation. A lot of these kids, especially as they get older, they may even need things like lung transplants just due to that kind of chronic inflammation. But certainly inflammatory bowel disease is a big one. So any of these things could all be signs of inflammation going on, which can again lead you to be in a state where you're not getting nourished as well as you should be. So looking at some of our anthropometric measurements that we can do. So these are important characteristics that we can measure on a patient to look actually for their nutrition status. So we can look at their weight. In some cases may not be super useful for us, especially with like very large patients, very obese patients. So we'll use a couple terms here, one being actual body weight. So this would be if you stand on a scale, get your weight, that's your actual body weight there. But in some cases, this can be greatly exaggerated, especially in obese patients. Some patients maybe what we'll actually look at is their lean body mass is. And so this is actually going to be kind of taking out a lot of the adipose tissue and extra stuff that is not really using a ton of energy. So we'll consider lean body mass being, or lean body weight being this kind of energy using component of the body. And in some cases, especially with patients with like large amount of edema or like ascites and things like that, it may not be super useful to use that kind of weight, because most of it's fluid, may not be, it's very labile, right? So you can do things like get rid of the fluid, and so what they can do instead is look at their dry weight, and so you can kind of estimate this based on kind of what their baseline might be, and so we'll consider that to be the weight minus all that increased body water they may have on board. We'll also use things like their stature. We'll use things like head circumference, especially in kids less than 3 years of age, to make sure that they're developing appropriately and growing as they should be. And then we can look at things like waist circumference, and then also bioelectrical impedance analysis. What is that, you think? Yeah, it helps to measure fat percentage by looking at the impedance of electrical activity. So things like fat and things like bone don't like to, they are not very well conducted as far as electricity goes, as opposed to things like water would be. So if you ever have like a device you can do like stand on a scale, or they can have like a little device you can hold on to, and so it'll measure that electrical impedance and give you an idea what the kind of the body fat percentage is going to be, right? And so you'll see that things like that may not be 100% accurate. There are going to be more accurate ways to do that, but it's good for tracking trends over time. You know, so if you check your patient, they have 20% body fat on day one, and then they come back 6 months later and now they've gotten 22% and they're 24%. Like that can be indicative of trends going on in certain directions. Looking at body weight, so I kind of alluded to this before, like in I think probably in pharmacodynamics somewhere. But again, ideal body weight is going to be this kind of population reference standard. Many people are not actually at their ideal body weight in a lot of cases. Some people may be under, a lot of people are over it. And so what we can do is look, and there's lots of different equations out there, so I'm not going to make you memorize these, but just realize kind of the components that go into the equations and kind of the concepts we're talking about here. But essentially, here's an example of a Devine equation. Devine was the researcher. It was not a church-based thing. Just kidding, it's a different Devine. Anyway, so this is an equation they use for ideal body weight. And so for men, they would use 50 kilograms as kind of their baseline, plus 2.3 times every inch they are over 60 inches. And 60 inches is how many feet? Yeah, every inch over 5 feet, essentially, you would multiply that by 2.3 and then add that on to that 50 kilograms. This is kind of trying to take into account things like organ size and organ weight and bones and all that kind of stuff, and then you're kind of including this additional factor based on how tall they are. Okay, for females, you'd start off with 45.5 kilos and then do the same thing, essentially, right? So on average, for the same height woman, typically they'll be a little weigh a little less than a man would of that given size. So this would be considered their ideal body weight, and this is used as a baseline to try to assess like kind of how far away they are from that, or how far under they are from that area. And so one of the things that we do, especially with a lot of medications that are going to be that are much more hydrophilic, things that have that don't partition a lot out into the tissues, especially with things like vancomycin or gentamicin, when we're dosing those, we don't like to dose based off of their actual body weight if they're very large. So if you think about like your 400, 500 pound patient, I think the max I ever saw was a guy who weighed 964 pounds. Yeah, it was basically, and he was coming in for difficulty breathing. Go figure. I mean, it looked like two little arms and two little legs sticking out from this giant mass of flesh and a little head at the top. But it was one of those things where like when you're dosing drugs based off of that, you can't use all that adipose tissue because of the way that the drugs are going to distribute out from that. So what we would do instead is we'd actually use, and especially for estimating things like renal clearance and whatnot, so what we do actually instead is use an adjusted body weight, which is essentially going to be taken it kind of shores up the difference between what their actual weight is versus what their ideal should be based on their height. And so for this, we generally use it if someone is above, their actual weight is above 130% of their ideal. Okay, it's kind of a cutoff. Again, different places will do different things. This is just an example of kind of what I would do if I was working, say, like in an ICU and I needed to do these calculations. But what we do basically is figure out what their ideal body weight is based on, say, like the equation above, and then we take the difference between their actual and their ideal. We just subtract that out, times it by 0.4. So notice here that difference there, we're kind of using just a portion of that. So about 40% of that additional weight they are above their ideal, adding that onto their ideal body weight. And now we have an adjusted body weight they can work with. Okay, so we can use that for things like calculating the creatinine clearance. We can use it for things like drug dosing. Again, is it 100% accurate? Not really, but it's the best way we can kind of fudge the numbers and make sure we're not going to necessarily overestimate a lot of things based on the fact that, you know, those patients have so much extra adipose tissue, right? If they're under their ideal body weight, you would still just use their actual body weight in that case, okay? Here's an example of how we can assess for growth in children. So you'll see these certainly if you do your pediatrics rotation, things like that, and you're doing your kind of well check visits. Essentially what you can do is look at both height and weight of the child, and you can also do this for head circumference as well, but usually the CDC will post these out, and you can kind of compare based on either the male or the female, and so you can look at the length of the child and versus their age, and you can kind of see where they fall on these curves. If they're in the 50th percentile, it means they're pretty average. If they're above or below that, you can also assess that as well. And then you can do the same thing for their weight. So you can kind of see where they're at, and you want to look for trends over time to see, like, you know, if they came in and they were 50th percentile on their say, you know, the 3-month visit, and they came in now they're at the 25th percentile at their 6-month visit, something's going on, right? They're obviously not going to be developing as well as they should. You know, is it because they're not being fed well enough? Do they have some sort of feeding intolerance? Are they not absorbing things very well? Lots of things can factor into it, but that should start to kind of tick off that thing in your mind saying, like, okay, well, maybe there's something going on here we should look at. Happy to say my baby has an above average head size circumference, so I'm saying it's all brain. Okay, so again, we can use body mass index to help kind of assess the overweight or how overweight a patient is, and usually an adult patient we're going to do. And so in this case, what we do is use their weight and their height involved in this. And so weight in kilograms. Again, most of the time you're going to be just dealing with weight in kilograms, so always convert pounds to kilos for these calculations. And then you'll see the height, and we'll basically use this and do it squared. I believe the height's in centimeters, but you'll find if you do like calculators online, because again, who do you think is doing this in their head as far as like a medical professional? Nobody. They have calculators that'll do it for them. Like I have an app that has a lot of the kind of common medical calculations that I do, things like body surface area, things like BMI, things like creatinine clearance. I just plug it in there and make sure it's right. So again, you'd end up using probably height in centimeters if I had to guess, just because I can't remember off the top of my head, but basically you'd square that and you're able to get your BMI essentially. So if they are, say, a BMI less than 17, they would be considered to be anorexic, meaning they're very much beneath what their ideal body weight should be. If they're 19 to 25, are considered to be healthy. 26 to 29 is considered overweight, and then anything above that would be considered to be obese. And so sometimes we'll use these kind of cutoffs to say, like, hey, you know, if you want to undergo bariatric surgery, you need to have a certain BMI for this period of time, and we'll kind of consider you for that. You don't want to have someone with a BMI of 20 and say, hey, I'd like to have a gastric band put on. I like to lose a little weight. Nope, you probably don't classify for that, right? So for instance, if you had a male patient who was 5'10", weighed 170 pounds, they ended up having a BMI around 24.4, so it'd still be considered a healthy weight. Now, female 5'5", 125 pounds, they have a BMI of around 20.8. Okay, so again, use your calculators, you can figure this out, and then kind of assess kind of where they're at. And again, you can track for things over time, which is also very useful when dealing with weight. So who do you think this would not be super useful for? The muscle bound. Yeah, so if you have a lot of muscle, this oftentimes will end up, because again, what weighs more, muscle or fat? Muscle, yeah, it's more dense, so it's going to weigh more. So if you have a particularly athletic person or someone who has a lot of muscle mass, they will typically be on the higher end there. So you can look at, you know, Arnold Schwarzenegger was probably classified as obese at some point because he weighed so much given for his height. So again, take it with a grain of salt, and always consider, you know, what's the actual condition of your patient. Don't just look at the number. Okay, so looking for some other laboratory assessments, things we can do to assess for clinical nutritional status over time. We can look at these visceral proteins. So the big ones are going to be albumin, transferrin, and pre-albumin. We talked about albumin before. What does that do for us? Carries stuff. That's a good way to put it. Carries drugs in a lot of cases. It's very useful for that. Carries things like bilirubin around, which is also useful. What about transferrin? What does that do? Transports iron, right? It's kind of right there in the name, transferrin, right? And then pre-albumin, we'll look at, also binds some other things, but we'll look at some of the differences between these and whether some of the shortcomings there. So they all get synthesized within the liver. And basically, if we see low levels, generally that's going to mean that we have some diminished amount of hepatic protein synthetic mass. And so if we see low levels of these, this would also indicate that it should have low amounts of the synthetic mass, or, you know, ability to actually do the functions of the organs in other places as well. It's very odd that you would have the liver just being dysfunctional as compared to like the heart or the brain or the lungs or anywhere else. And so we kind of use these as our surrogate markers to see kind of what their nutritional status is, that they're producing these proteins as they should. Many factors will affect this, so things like age, nephrotic syndrome. So nephrotic syndrome we mentioned, normally albumin doesn't cross the glomerulus. Why does it not do that? that negative charge, right, just bounces off that basement membrane, can't cross there. When you have that minimal change disease, when I mentioned you start to lose that negative charge, you'll have proteinuria, and that can lead to nephrotic syndrome, where you're losing a ton of protein. That can end up causing differences there, right? So again, you're taking multiple things into account when you're looking at this. GI tract loss, if you're losing a lot of substances, a lot of nutrition through the GI tract, that can affect this. Burns and stress are big things. So burn patients tend to be a very hypermetabolic state. They will end up burning through a lot of these proteins very, very quickly. Trauma, surgery, all these things can all be affecting this. We'll look at some of a little bit of the differences and some of the caveats with these. So looking at them, you can kind of see the albumin, comparing the half-life for these in days, about 18 to 20 days. So albumin sticks around for a decent period of time, transferrin a little bit shorter period of time, and then a pre-albumin has the shortest period of time. So which one do you think would be really good for looking at chronic changes in nutrition status? Albumin, right? Because it sticks around for the longest, so it's going to be the least sensitive to some of these changes that occur, the acute changes that happen over time, versus something like pre-albumin. It's going to be much easier to check for things that are happening over the course of weeks, versus albumin, you're looking over the course of months, essentially. So again, albumin is very important for establishing that oncotic pressure. What happens if we lose albumin in the bloodstream? Where's that fluid like to go to? It's going to start to third space out. It's going to go in the extracellular fluid. Someone's going to go in the intracellular fluid. It doesn't stay in the intravascular space, which is why you can see patients who have low albumin, you run into issues where they have excess fluid loss from the kidneys. They'll also have fluid building up in the interstitial space, so like the ascites, edema down in the ankles, places like that. And that could all be related back to low albumin levels. Transferrin we mentioned is going to be useful for carrying iron around. We'll talk about that in a minute or two. And the pre-albumin is mainly going to be binding to thyroxine or thyroid hormones. So that actually helps carry that. Also some retinol binding proteins as well. So we'll go into more detail on these. So albumin, being the most abundant of these visceral proteins, or the serum proteins in general, helps to maintain that colloidal oncotic pressure. So we need that in order to help keep fluid within the intravascular space. And again, it's not really great for looking for acute changes in nutritional status, mainly because we have a huge amount of it, not only in the bloodstream, but also in the tissues. So about 4 to 5 grams per kilogram of body weight. And then it also has a very long half-life. So it sticks around for a while. So you're not going to be able to detect these kind of changes over periods of months. But certainly if you have a patient who came into you and they already had a low albumin level, that should tell you something. That should say, okay, well, they've probably had a chronic issue that's been going on for at least some period of time now, if it is truly indeed related back to their nutritional status. That's a good marker for chronic malnutrition, not great for acute malnutrition. And again, low levels causes exacerbation of edema because they have less oncotic pressure, so pulmonary edema, ascites, all these things can pop up there. And so you can also find that it will affect certain lab values as well. So calcium actually likes to be bound to albumin, and so if you have low calcium or low albumin levels, that can actually affect the total calcium level you measure. So we have actually some factors that we will build into that. We have calculations we can do to actually kind of correct your calcium level based on what the albumin actually is, right? And then certain highly bound drugs, if you have less albumin around, less of the drug can be bound to it. Let's say you have a higher amount of drug that's free and can actually be working on the receptors. So I mentioned that drug phenytoin, which is a seizure medication. When you have low albumin levels, a ton of it ends up being free. So even though your level looks good, they end up getting really toxic from it because of that. And then a transferrin, this is going to be a little bit better for looking at acute changes, but again, still going to be sticking around for a period of time. So it's a little bit better, but it can also be used for kind of chronic issues of malnutrition. But again, it's usually going to be transporting ferric iron to the liver and also back to the reticular endothelial system for recycling of iron. Basically, we have less of it in the body, so it also, when you have a nutritional issue that is leading to you not producing transferrin, it also clears out faster. It's a shorter half-life and less of it actually in the body itself. And then finally, pre-albumin, this is a really good one for looking for acute changes in nutritional status. And so, for instance, if I have a patient who comes in who is chronically malnourished, I can see that they would have a low albumin level, right? And they would also have an issue where they have a low pre-albumin level, right? So I could look at that as well. And then as I'm giving them nutrition, say through like a total parenteral nutrition, giving it through the IV, the first thing that should respond to that would be, what do you think? The pre-albumin. So I can start to see the pre-albumin come up, and then eventually I should see the albumin coming up afterwards, right? Because again, as you see those changes, it'll happen much more quickly as they reach a new steady state, essentially. So this can be very useful. Again, low body stores of it, short half-life. It's going to be a good marker for acute changes, especially if a patient is on an NPO status, which what does that mean? Nothing by mouth, right? And then also if they have like trauma and burns, again, those patients go through a ton of proteins. They're very hypermetabolic. There's a lot of fluid, so this is another good marker for them as well. So starting to get into some of the nutritional requirements we have. assess them. So again, requirements are going to vary pretty widely based on the age of the patient, the gender, the size of them, the disease states they have, and just their clinical general condition. And so you need to really assess them, see what their current nutritional status is, see what their physical activity is, and then figure out, okay, do I just need to maintain things? Do I need to replace them? Or maybe I need to actually start to underfeed them a little bit to try to get their weight back down into a good range. And so the course assessment is going to be key for this, and of course the nutrient requirements are going to vary greatly based on organ function as well. So we'll see some differences when you have protein, kidney dysfunction versus liver dysfunction, how that can affect your requirements. So recommended daily allowances. I'm sure everyone's read the back of their food and seen these recommended daily allowances. First established back in 1941 and have been kind of updated occasionally. I think one of the last updates, at least the book I was reading had, it was 1997, but they'll have some individual updates for things as we go along. I'll show you an example of that. Basically, you can have these daily reference intakes, or the DRI, and they can be broken into a couple of different components. So when you have the estimated average requirements, this is basically the requirement that would meet the needs for about 50% of the people for a defined group. So if I was saying for healthy adult patients, male and female, this would be the amount that would roughly satisfy their need in about 50% of those patients. Okay, it's probably not what we're going to recommend people intake, because we like to hit more than 50% essentially. So that's where the recommended daily allowance comes in. That if you give that amount to people in that particular group you're defining, that this should be able to meet the needs for all people in that designated group. Okay. So again, your RDA would probably be a lot bigger than that as the estimated average requirement, right? So and looking at adequate intakes, this would be used for things that if you don't really have a good estimate of what the recommended daily allowance is going to be, like we can kind of, this is for certain nutrients and certain vitamins, we'll use this adequate intake, saying that, okay, well, this should be enough to cause metabolism and cause appropriate growth and all these sorts of things. And then finally we have the tolerable upper intake level, which means this is the upper amount they should be taking, beyond which you can probably start to see toxicity, right? So can you overdose on vitamins? Absolutely, right. So especially what type of vitamins? Yeah, so we'll talk about fat-soluble vitamins, how they're much more likely to see toxicity from those, and why that is in just a little bit later. Okay, but again, they can revise things as they go along. They realize that a lot of people have kind of chronic vitamin D and calcium deficiencies. We'll see how those two are kind of intrinsically interlinked there. So they increased the recommendations for those back in 2010. Okay. And they also recommend, and again, this kind of varies widely based on the patient, if they're adult, if they're a pediatric patient, kidney disease, all sorts of things. But in general, they roughly recommended around 45 to 65% of your calories as carbohydrates, 20 to 35% is fat calories, and then 10 to 35% being protein calories. Some mixture of those should end up to get 100% eventually. Yes?
So, but those numbers are only good for 50% of people.
Basically, you'd be shooting for the recommended daily allowances. So like when you're looking at like the back of your potato chip bag or whatever you're looking at, like, you should have the recommended daily allowances and what percentage of that you're hitting with a given serving of the food you're looking at. So that's kind of what they shoot for, because they want to make sure that they, but when you're actually looking at individual nutrients, they can go back and say, okay, here's what the EAR is, here's what the RDA is, and they can look at all those different things. So again, clinically, you'll probably end up seeing the recommended daily allowance being referenced most often. Okay. So of course, we know that most of our energy, the ATP, is going to be ingested from our carbs, our fats, and our proteins. So these are our macronutrients, as you guys know. All these can be converted eventually over to acetyl-CoA, where they can go into the citric acid cycle, oxidative phosphorylation, and boom, we have ATP, right? Basically, the kind of the average we're going to look at here is that, of course, 1 kilocalorie is going to be equal to 1,000 calories. And normally when you're looking at calories on a label or something, it's referencing kilocalories, even though it might not say that. And so basically, the 1 calorie is equal to that energy needed to raise 1 cubic centimeter of water, 1 degree centigrade. Okay. That probably doesn't actually matter for anyone clinically anymore, but we just say that's what a calorie is going to be. So essentially, and when we're calculating the energy requirements for patients, we're trying to figure out what proportion of carbs, proteins, and fats that they need, we'll use this general amount that 1 gram of carbohydrate or 1 gram of protein equals 4 kilocalories, and 1 gram of fat equals 9 kilocalories. Okay, that's kind of an average. You can kind of use that from here on out. So, and we'll look at equations that we can use to see what their calorie requirement should be. And then we'll be able to figure out what kind of protein requirement they have. And then typically we'll figure out what kind of fat requirement they have. And then once you have those two, you just supplement the rest of it with carbohydrates, essentially. Okay, so that's usually kind of the way we do it when we're looking at TPN patients. We're starting them out on that. We say, okay, well, what's their calorie requirement? How much protein do they need? That's usually the first thing we figure out. How many fats they need, and then we'll figure out the carbs based on whatever we need to supplement with. And so anyway, when we're determining those energy requirements, we have our daily energy expenditure, which includes things like the basal energy expenditure. This is just going to be the amount of energy you need just to live, just for your normal metabolic functions to actually occur. We'll also include this diet-induced thermogenesis. What do you think that is? Yeah, it takes energy to break down food, right? So it takes money to make money, it takes energy to make energy. So this is including this diet-induced thermogenesis. So you do burn some degree of calories in consuming food, and then actual energy used for physical activity that we're going to be factoring in as well. Usually for sick and injured patients, so those are like in the hospital, you're going to find they will probably have a stress-related hypermetabolism, which will increase that basal energy expenditure. They'll probably end up having decreased physical activity because they're probably going to be laid up in bed for the most part. And so based on this, it's easy to overcompensate and say, well, they're hypermetabolic. Let's just go ahead and give them all these extra calories, and you don't factor in the fact that they're not moving around like they used to. You know, if you have a guy who was a landscaper and he's out working out in the middle of the Florida sun, 10 hours a day, he has a pretty high energy requirement based on his physical activity. Put him in a hospital bed, now he's not having all that energy outflow, and so you can overfeed them, and that can lead to problems. What's an issue do you think they could develop by overfeed patients who are sick in the hospital? What happens to their blood sugar, do you think? Goes up? Okay, good. And what likes to eat sugar and reproduce? Bacteria, right? So this is why you'll find that there are usually some guidelines, especially for critically ill patients, where they say, well, we'll put them on insulin even though they might not be a diabetic patient, because when you have the stress-induced hyperglycemia, we like to keep that in check because it can lead to one, infection, right? So bacteria like to chew up the bacteria or the glucose. The other thing is that having too much glucose around can be pro-inflammatory, so it can actually lead to worsened inflammation for some of these patients as well. Okay, so there's lots of recommendations about giving insulin during cases of stress-induced hyperglycemia. There's lots of ways we can calculate the caloric requirements. Here's one example where it's just based on a kilocalorie per kilogram amount. So for instance, if you had healthy, normal nutrition status, minimal illness severity, so most of you guys will probably fall into this, you do 20 to 25 kcals per actual body weight per kilogram per day. Okay, that's a pretty good, decent number, but of course, what might be a shortcoming of this? Yeah, so we'll talk about adding in some of the additional micronutrients and things like that. But think about, if you have particularly large patients or small patients, think about the physical activity that they're undergoing. This is good for, again, minimal illness, which is why we kind of have this further breakdowns into if they are critically ill, if they are very large patients. And so you'll notice, say for instance, if they have illness, they're having increased metabolic stress, so say they're post-surgery, if they have infection, whatever, if the BMI is less than 30, we'll notice again, we're going to increase that calorie amount. So say we'll go 25 to 30 for them. Okay, per kilo. If they have illness and they do have a larger BMI, so they're above 30 kilograms per meter square, it might be 11 to 14. So you notice, why does that go down, do you think? Yeah, so again, they have less actual metabolic tissue. All that fat does not necessarily need all that extra ATP and whatnot. So we'd actually end up lowering the amount. Or if we were using their ideal body weight, you'd still notice it's pretty similar to what the actual amount would be for someone. And again, in a lot of these cases, we allow for permissive underfeeding, which means we may actually be shooting for less than 100% of what their actual calorie requirements are, based just on their weight. And that way you kind of lead to less of that hyperglycemia, because we know that's not going to be good for them in the long run. Yes, ma'am? Nope. Okay. And then looking at something like a major burn injury, so these are going to be patients that have, say, greater than 50% total body surface area. I never forget, I saw one patient who came into the trauma center. He was smoking at home. He had a natural gas grill, and he had oxygen on. Oxygen and flames do not go well together. So he's smoking, has natural gas, and just basically turned himself into a crispy critter. Did not go well for him. But they are super hypermetabolic. So always think about that, guys. He was just so much energy requirement. So they may need greater than or equal to 30 kcals of actual body weight per kilo per day. Sometimes may even go above that, because they're in such a hypermetabolic state, trying to regenerate all this new tissue and whatnot. So again, they've seen that by using that permissive underfeeding, it's not just mean to say, well, we're just not going to feed you enough. That actually decreases infection rates and also shortens length of stay, which is a good thing for patients. Okay, but it probably doesn't work perfectly for every single patient, especially those that are kind of at either extreme of height or weight or different things like that. And so there's a few that we have that you'll use probably more commonly if you're doing these kind of calorie calculations. The old one we have is the Harris-Benedict equation. It's back from 1919. It was based on 239 patients. So how applicable do you think that is to the general population? probably okay for some people, but there's probably going to be a lot of people who kind of missed out on that, right? And so again, people from 1919 probably had a much different diet than we have in 2017, okay? So because of that, they found that there were some issues with the measurements, or issues with, and basically they were looking at healthy patients, looking at oxygen consumption, and they were basing that, figuring out how much calorie requirements they're using and things like that, which I won't really get into too much detail on, but basically, I found this is pretty inaccurate, so I don't really use Harris Benedict anymore, so I include this here just for posterity's sake. But now what we use more often is this Mifflin-St. Jeor equation. And so oftentimes if you go online, you're looking for like calorie calculators, a lot of times they'll end up using Mifflin-St. Jeor. It's kind of the standard now, but they found to be more accurate, and they also can incorporate a stress factor, which I'll mention in a second. So you notice here that it's going to be using the weight, also incorporating the height of the patient, and then looking at their age. This is also a nice thing because it will factor in the age and the fact that as patients get older, they tend to be less metabolically active than a younger patient. So for example, if I had a 70-kilo male who's 70 inches, and he's 40 years old, I can plug in all that information here. You notice that based on his weight, and again, the 700 calories plus his height, kind of giving me what else is kind of making up that metabolic rate, and then I would subtract out the fact that he's 40 years old by removing about 300 calories almost. So for him, I would say, okay, you have a basal, a resting metabolic rate of essentially 1,540 calories. Now, that doesn't include any kind of stress factors, so in some cases you may see, well, if he's having moderate stress, we'll increase that by 1.2, right? So we'll multiply the whole thing by 1.2, probably get him up around 1,800 calories or so, right? So we find a lot of patients maybe under that kind of 2,000 calorie kind of ideal that you kind of probably were raised kind of hearing about. A lot of your nutrition labels and stuff like that are still based off of 2,000 calorie a day diet. But essentially here, this is a much more accurate way to determine what that individual patient's calorie requirements are going to be, and then based off of this we can figure out what his macronutrients are going to be, so proteins, fats, and carbohydrates. Again, I'm not going to ask you to calculate that on a test, but just be aware of what we're kind of incorporating in here as far as when we're trying to figure out what their energy requirements are. Okay, so for protein, we'll see that the recommended daily allowance is roughly 0.8 grams per kilo per day. Do you think most people are probably over that or under that? Yeah, a lot of people, especially with the typical U.S. diet, we're probably a lot over that. Maybe if you're like in France and you eat a lot of cheeses and breads and wine, probably under that. But here in the U.S., though, we're probably over this more than anything. But you'll see, especially like hypermetabolic patients, they tend to be going to have an increased protein requirement, right? Because we need to break down and get those amino acids so we can start to either get rid of that infection, regenerate that tissue, whatever it happens to be. So they may be, say, 1.5 grams per kilo per day. We'll up that in some of our older patients. This helps to account for that decrease in lean body mass, because we know that as patients get older, they tend to lose muscle mass. So we'll up their requirements, and for older patients, if they have infection, trauma, surgery, they may be anywhere from 1.5 to 2 grams per kilo per day. Okay, so again, this is already going to be that chunk of your calories for the day that are going to be factored into this. And so if I wanted to figure out, say, I have a 100-kilo patient who had a major trauma, and I want to give him 2 grams per kilo per day, he'd obviously be getting how many grams? So 100-kilo patient times 2. 200, good. And then how many calories per gram of protein? 4, right? So so to figure out how many calories are being taken up by his protein, you say 200 times 4, 800 calories. Okay. So we had, if the patient was on a 2,000 calorie diet, you say, okay, well 800 of that was already gone. The other 1,200 is going to be made up of fat and carbohydrates. Again, we'll look at the fat requirements in just a few minutes, but essentially, the whole goal here is to provide enough protein so the body doesn't have to start breaking down its own stores. So again, when you're dealing with a critically ill patient or someone who's having an infection, you're trying to prevent that catabolism from occurring there, that breakdown of muscle. Okay, so be careful, patients with liver or kidney dysfunction. You can sometimes end up having either spillage of protein to the kidneys. You can have buildup of protein. So you may find they have altered recommendations based on what their kidney or liver function is. Okay. Also, we see that there are non-essential and essential amino acids. What's the difference here? Yeah, so the essential ones are ones that we have to take in from our diet. We cannot produce these on our own. And so, again, most healthy, balanced diets will contain a decent amount of all of these. So, again, not only from red meats and things like that, but certainly from grains and certain fruits, and we'll be able to get us all these amino acids that we need. Okay, so just kind of the difference there. I'm not going to ask you to memorize the whole list to be like, wait, which one of these is not essential, because you guys can look that stuff up. It's probably not super useful clinically, but just be aware there are essential and non-essential amino acids. And then looking at fats, they also recommend about 10 to 35% of those kcals are going to be from fat. So for instance, if I had a 2,000 calorie diet and I said, okay, I want to give this guy, say, 20% of that being fats, that'd be roughly how many calories? So 2,000 calorie diet, 20%, I want to make that be from fat calories. So be 400, right? So 400 calories are going to be making that up. And then basically we said how many grams, 1 gram of fat is equal to how many calories? 9. Yeah, so we take that 400 divided by 9, and that would give us how many grams of fat that we need to give to these patients, right? So in the case of like total parenteral nutrition, we have a product called Intralipid that we'll give to them. It looks like basically looks like you're having infusing IV milk. Very kind of cool looking substance. But basically, you'll kind of figure that, and especially for like young kids, we'll find they'll actually increase their fat requirements. So they may need 30 to 40% of their fat calories going to be for the first couple of years of life, because again they're still developing. They still have they still need to be putting on weight at a pretty consistent rate. And so they recommend, like, especially when you switch a kid from like breast milk over to cow's milk, like just give them full fat milk. Even though if everyone else drinks skim, they recommend really not kind of withholding that fat from kids that early on. Let's say have a specific recommendation to do so. And basically, we want to make sure we prevent this essential fatty acid deficiency. And so there's 2 different fats that we have to have in our diet because we cannot synthesize them on our own. This is going to include the alpha-linoleic acid. This one is required, essential. It's going to be an omega-3 fatty acid. And then we have this linolenic acid, which is going to be our omega-6 fatty acid. So both of those are essential fatty acids. We have to get into the diet. We cannot synthesize them on our own. Okay. So you can see lots of different sources you can get from here. Certainly, soybean oil, just normal cooking of lots of different foods, you'll be able to get these fats in pretty easily. But again, if you have an issue where you have fat malabsorption, so I mentioned before that drug that would block fat absorption in the stomach, right? So they would end up having those kind of greasy, oily kind of stools. They could end up having this fatty acid deficiency because they were blocking absorption in the first case. Or if you have kids who are not producing enough lipase on their own, they may not be able to absorb these in a decent enough rate. So they would be at risk for having this essential fatty acid deficiency. So, and then also you have to consider the fluid balance for the patient. So intake should generally match output as long as you don't have any issues where you're already edematous to begin with or dehydrated. On average, the adult patient will require about 30 to 40 mLs per kilo per day of fluid. Okay, this is to account for both sensible and insensible losses of fluid. What's the difference between sensible and insensible? Yeah, the insensible, you can't really measure that directly. So for instance, fluid losses, you can measure urine output, you can measure stool output, but you can't really look at how much vapor is being breathed off in the lungs. You can't really measure the sweat so much. It'd be very difficult to do so. So you have a pretty decent amount of this being lost to insensible losses, but we want to account for this by giving them actual fluid, either whether it be oral hydration or whether it be through the IV, whatever happens to be. So again, we're trying to really balance this out. For most adults, it's probably going to be around 2.5 to 3 liters or so. It's going to be pretty sufficient for them. Some reasons why you may have increased fluid needs versus decreased fluid needs. So again, increased requirements. If you have fever, if you are already hot to begin with, you're going to be having a lot more insensible loss off the skin. So we want to look at that. If they're having diuretics, vomiting, nasogastric suctioning, any of these things can be increasing release of fluids out of the body. We actually have some patients who will have orders for fluids where they are on a replacement basis. So for instance, if you have a kid who has, say, like a shunt put into the brain, they can end up having CSF or cerebral spinal fluid actually coming off of that. And so as they're draining it out, say for instance he's producing way too much, it's causing pressure issues in the brain, you can try to get that out, and we'd actually cause, we'll give them replacement on that back through their IV. So we do it on like an ml for ml basis depending on the situation. But certainly all these things where you're causing increased fluid losses, you're going to need to replace that at a higher rate. Okay. Decreased requirements, they already have fluid overload, they already have heart failure, renal failure, all these things can end up causing you to hold on. You're already holding on to too much fluids. You don't necessarily need to be giving them too much back. Again, remember the syndrome of inappropriate antidiuretic hormone, right? That's IDH. Again, those guys are not able to put out enough of the aquaporin channels into the collecting duct, and holding on to too much fluid, and so we have a decreased requirement for them as well. Even though, what would their desire for water be at that point? Be pretty high, right? That thirst center is still being kicked off, even though they are holding on to too much water to begin with. Okay. So moving on, that's kind of our macronutrients is kind of, and again, as far as like the carbohydrates go, I didn't cover those too directly, but again, once you figure out your protein and your carbohydrate and your fat requirements, you just supplement the rest of the calories essentially with carbohydrates. Usually if you're doing it IV, it's going to be in the form of dextrose in a lot of cases. That's usually the most common one they'll end up using IV. Okay, moving on, talk a little bit about, what is it in Breaking Bad, and he's like, they're not rocks, they're minerals. Anyway, I guess not a lot of Breaking Bad watchers. Anywho, so looking at this, minerals, these are going to be these non-organic molecules that oftentimes get used as cofactors in a wide range of metabolic processes. If you're missing any of these for a long period of time, usually the body is going to have a store of these. This is why over several months, though, as you become more deficient, these conditions will become more apparent. So again, things that you need in large amounts every day is going to include things like sodium, potassium, magnesium, phosphorus, all these kind of minerals here, calcium, chlorine. So again, those will be coming in mostly through the diet. Then we'll talk about trace elements. We call them trace elements because you don't need a ton of them, and I'll show you some of the daily amounts that you're going to be required for things like zinc, manganese, fluorine, molybdenum, chromium, all these different things. But these are super, super important because you're missing these, a lot of enzymatic processes go haywire, and you can lead to some pretty significant metabolic conditions. So sodium, again, I'm not going to cover every single nutrient out there, but just some kind of broad things we'll talk about here. So again, sodium, usually recommended to get around 2,300 milligrams or less. Do you think most patients probably go over that or under that? Probably over, yeah. So again, just if you go look at like your cup of noodles or something like that and just see how much sodium they contain, some of that stuff is pretty crazy. But again, they can see, do you know what they used to use as salt replacements? So we don't want you to get enough sodium, so we'd replace it with something else. Yeah, so potassium can sometimes be used, so that can be problematic if a patient's like, well, I'm supposed to get all the salt out of my diet, so I'm going to use potassium replacements, and they have renal problems, you can hold on to too much of that, they have cardiac problems, that can be an issue. They actually used to use lithium as well as a salt replacement. That was back well in the day. Everyone's in a great mood, but unfortunately, caused some other issues that came up, so we'll talk about that when we get to the psych section of pharm. And calcium, super important. Most people are probably going to be deficient calcium, also because they're going to be deficient in what other vitamin? You guys know? Yeah, vitamin D is going to be the big one there. So again, usually recommended, 1,000 to 1,300 milligrams. Also dependent highly on the type of patient and what other conditions they have going on. So if they're pregnant or lactating, certainly have an increased requirement there. They're older females trying to prevent osteoporosis, this can all be really needed there as well. And you can see some of the sources. I won't go over in super detail there. But one other big thing to worry about with calcium, common cause of constipation, right? So again, you're telling these older patients, hey, you need to get lots of calcium in, you want to prevent osteoporosis. They're also complaining of constipation. Most of the time it's going to be related to that calcium. And again, it makes sense because you have increased calcium. What does that do to smooth muscle constriction? Usually cause it to be more constrictive, right? Because calcium's needed to come into the cells. That causes smooth muscle to constrict, and so that can lead to issues where you may not be having proper peristalsis. Things can kind of be held up in the system, and so constipation is a very common complaint, especially with older patients, especially if they're dehydrated and things aren't moving along what they should be. It's not necessarily spasming, it just kind of slows everything down for the most part. So we have issues where too much calcium can do that, but also if you had something like a calcium channel blocker, a common side effect from those is also constipation as well. So anything you're kind of altering the amount of calcium able to get in or out of the cell can affect that. So again, looking at the trace elements, so again, these are essential in humans. They play a big role in normal metabolism. So we'll see these being used as coenzymes, affecting hormonal metabolism, and erythropoiesis are also going to be some big things as well. You kind of look here, these are your main trace elements, and it's really important that we have these maintained. Again, usually the body has a big store of these, and so missing out on zinc for a few days, probably not going to be a problem, right? You ever hear about I'm sorry, I'm trying to think. Just lost it. Anyway, so looking at these trace elements, you usually have some pretty good stores of, but chronically malnourished patients are going to be basically deficient in this, and this is where you can run into some of these problems. But zinc only 8 to 11 milligrams a day. Things like chromium only 20 to 45 micrograms per day, but they're very important when they're not there. So it's kind of things you kind of take for granted because most of your diets are going to be pretty overabundant of these anyway. Okay, I think I'm actually going to cut it here. Is that all right? I'm going to record an extra video before the review. I'm not sure how many slides I have left. Probably a lot. A lot, yeah. So I'll record an extra video before the review. I'll let you guys go a few minutes early. Stay here because I need to go get Shirley to come go over registration stuff. Any questions before I leave? Okay, can one of you guys actually go get Shirley? I don't know, draw straws. Thank you. Okay, so we'll cut it there and we'll post to the video.